Started. Well, welcome to March 2021 and this version of Arizona Community Grand Rounds. My name is Mark Carroll, and I'm the Chief Medical Officer for Health Choice Arizona, which is part of Blue Cross Blue Shield of Arizona. Really pleased to help facilitate these rounds with Mary Jo Gregory, the President and CEO of the NARB Institute. These rounds occur roughly once monthly, sometimes twice. We're really pleased to have a terrific set of presenters today on a very timely and important topic. But if you have ideas for topics and presenters that you'd like to see present on these rounds, please don't hesitate to reach out to me, Mary Jo, or any of us, and let us know your suggestions for those rounds. Today, we're going to actually present on innovations in vaccine outreach with folks representing 3 counties who I'll introduce as they present, representing Coconino, Maricopa, and Pima counties. I do want to acknowledge very importantly before we begin that we have 15 counties in Arizona all doing superb work and addressing the outreach that's necessary and the very local and specific type of collaborations that are key to having vaccinations occur that meet local needs and scenarios. So we want to acknowledge that. Unfortunately, within 50 or 55 minutes, it's a challenge to have updates from all 15 counties. But we welcome ideas. We welcome your sharing either through the chat or Q&A function, or just separately the learnings and lessons that you've had in other counties that won't be discussed today. I'd also like to thank Charlton Wilson, Dr. Charlton Wilson, the Chief Medical Officer from Mercy Care, for joining us today to help just reflect back and have a discussion during the presentations today. So let's begin. We've decided without the flip of a coin, but that we would go north to south and begin with first presentation from Coconino County. So I'd like to introduce Mike Oxtoby. All 3 presenters today, I'm pleased to say that I've had the great privilege to get to know and would call not just colleagues, but friends. And Mike and I have worked together for many years. Mike is the Deputy Director of the Coconino County Health and Human Services Department. He's been in that role for about 7 years now, but 20 years plus in public health. And before that, actually worked in regional behavioral health. So Mike has quite a varied level of experience, and we're really pleased that he could join us today. So Mike, I'll turn it over to you.
Thank you, Mark, and thank you, Health Choice and the NARB Institute for inviting Coconino County to share its experiences. So Jennifer, if you could open up the presentation, please. Okay, so next slide, please. So we were asked to share with you Coconino County's experiences, learning, priorities, and innovations as it relates to vaccinations. Next slide, please. So March 2020, that's when the emergency declaration was declared at the state level and also at the county level. We have been operating under an instant command system structure for the last year plus. It is a very active team. Currently, I serve in the role of Deputy Incident Commander overseeing operations. Next slide, please. And so I know we want to talk about vaccines, but I really feel the importance of calling out TGen and their TGen North and their efforts at helping Health and Human Services with swab testing. They were at the forefront from really day one, and their ability to process test samples quickly allowed us to do investigations and contact tracing very quickly as well. So a huge shout out to them. We were also involved in setting up an isolation and quarantine hotel in the early days. We are since downsizing that due to the reduced demand. And then our testing site was at Fort Tuthill. We've transitioned that over to a vaccination site. We're doing about 70 vaccines per hour. And then, of course, like everyone in the state, the vaccine administration in those early days, the ability to count on reliable, predictable shipments every week was a challenge, but things have gotten gradually better. And I think we feel like we're in a better place than we were, say, in January. Next slide, please. And so one of the things that we learned through this entire process is the importance of communication. And so let me share with you what that looks like for us. Um, we found it really important to engage our stakeholders in routine and frequent communications. And so every Monday, we have weekly operations briefings with these partners. And for about 30 minutes, we provide updates, we respond to questions, just so that they have the current state of affairs as it relates to Coconino County. One thing that was sort of surprising to me is the partners who were not in the information loop. I can remember the early days of the long-term care facility, the rollout with the federal pharmacy program. We had long-term care facilities in the county who had not had any contact, and they had signed up for the program, but really didn't know when it was going to begin and what the schedule was going to look like. So we worked closely with the Arizona Department of Health Services and secured such a schedule and shared that with the long-term care facilities, which I think made it easier for them to sort of plan and facilitate their operations. And I also want to make another shout out to Dr. Carroll. So we had received some inquiries from the DES-DD system on vaccinating those individuals. And quite honestly, it was an audience that we had very limited experience with. And so he was able to bring the parties together. So the local health plans and the Course County Health and Human Services, and pleased to report that as of about a week ago, 36% of the DES-DD members have been vaccinated, have received at least one vaccine. And then the hard to reach populations. I think every county is challenged by this, and we're no different. And what we learned back in the testing phases was the importance of having a periodic presence in these outlying communities. And many of you know that Coconino County is a very rural and dispersed population. It's the second largest land-based county in the continental US, poses many, many challenges for us and those communities. And so we had a guiding principle that said we would be present for on-site testing 2 to 3 times per month in these given communities. And we're also doing that with vaccines as well. And I think it's a reminder to the communities that they're not ignored or forgotten. Next slide, please. And then, of course, keeping the community at large informed. So here you have pictures of a couple of our board members, our county manager, and to the far right is our Health and Human Services Director, Kim Musselman. And so sharing information at the board level, the public level, city and town councils, and a heavy reliance on social media, which has been proven incredibly helpful to us. And also the importance of communicating in multiple languages and dealing with misinformation. Next slide, please. And so the 3 most common myths that we experienced in our call center and elsewhere was you had to, excuse me, you had to be a citizen to receive the vaccine. That was not true. You had to pay money to get the vaccine. That also was not true. And that one vaccine is more effective than another. And we know that all vaccines were FDA approved and equally effective at preventing severe illness and hospitalizations. And so it was our effort to sort of send the message that was basically don't delay in getting vaccinated. When it's your turn, please sign up. Next slide, please. And then we relied on some trusted community leaders. So we had people from education and healthcare and law enforcement just to sort of help promote the importance of the vaccine. Next slide, please. And then we took a lighthearted approach when it came to dealing with some of these priority groups. And so you'll see the image there with the roll of toilet paper that says if you get asked when the toilet paper shipment is expected to arrive, you're eligible to get the vaccine. That was our message to target the grocery industry. And then in the lower right, you'll see if you take a deep breath when a large party comes in 5 minutes before closing, you're eligible to get the vaccine. Again, that was targeted at the restaurant industry. And then, of course, we have a couple of images there for education and those people who are 65 and older. Next slide, please. And so we wanted to ensure that information was accessible to all. So in this county, we have many languages that are spoken beyond English. So we have Navajo and Hopi and other tribal native languages, as well as Spanish. And so we used Google Translate, Facebook Translate to help with our messages. We had a language line where people could call in and speak to an operator who spoke their native language. And then more recently, we've begun to partner with churches to outreach to the undocumented community, because there is concern and suspicion by that group of what happens if they come to a government-sponsored pod. And so we want to assure them that there is no they're not going to be reported or anything of that sort. And I would like to shout out to Pima County and Terry. We're sort of relying on the model they used of a few weeks ago, and our Northern Arizona Interfaith Council reached out to the Southern Arizona Interfaith Council, and we're sort of comparing notes and designing a system that is suitable for Coconino County. And then we've also involved, the county has several diversity councils, and we've invited them to help us with messaging and also outreach to the community. Next slide, please. And so again, the priorities going forward are those difficult to reach populations. I spoke earlier about the vast rural nature of Coconino County, and we're really happy to report that we recently received funding from the Department of Health Services to establish a mobile vaccine program. So we're going to secure a vehicle and staffing and be able to outreach to these communities that are sometimes 2 and 3 hours away from Flagstaff, particularly those who lack access to public or personal transportation. And then the other challenge that we're coming upon is the homebound. This is an area that is entirely new to Coconino County Health and Human Services. And I know that health plans have reached out to us, and we have much to learn. And so we're really looking to engage in that conversation of how do we proceed? Who are the stakeholders we need to bring to the table to best serve this audience? Because obviously it's a vulnerable population that could benefit greatly from homebound vaccinations. Next slide, please. And then so innovations, I mean, some of this doesn't sound very innovative, but it was at the time for us. In the early days, the unpredictability of the vaccine, whether it was the amount of shipment or when the shipment would be received, really sort of played havoc with our scheduling system. And so once that rhythm and that pattern became more predictable, we then promoted the opening of appointments on Fridays at noon. And I think it did a number of things. It helped our internal operations with planning and staffing, traffic control, but it also helped the public know that they didn't have to be up at all hours of the night to sort of find an appointment. And we've been fortunate to have partner vaccine pods within the county beyond what the County Health and Human Services Department has done. So we have Flagstaff Medical Center, who has been a huge partner with this, vaccinating upwards of 500 people per day. And their location is really ideal because it's near a public transportation system, and it's also within walking distance of several neighborhoods. And NAU has a pod, but it's on a much smaller scale, but they have been a contributor as well. I mentioned earlier about the COVID-19 information line. We have individuals in our community who English is not their first language, or they struggle with technology, whether they lack the equipment or the comfort with it. So they can call this information line, and we have people who can walk them through the registration process, get them set up with an appointment, and sort of get them vaccinated for their first and second doses. And really, it's all been about partners, partners, partners. This is far too heavy of a lift for a single provider to do. We welcome and really need the involvement of many others. And so for us, we've been able to develop some partnerships with some new individuals and entities we didn't have much of a working relationship with the ESDD system and some of the health plans, and even some of our private employers. And so we feel pretty good that we can promote the value of public health and be of service to them. Next slide, please. So this is our final slide, and this is really about the trusted colleagues. And these images illustrate the commitment and resilience of our healthcare staff. And so in Coconino County, both testing and vaccinations, we've have taken those activities have taken place in below freezing temperatures with sometimes 2 feet of snow on the ground. And no matter how fatigued and cold these staff are, they simply never quit. It is an incredibly resilient group. And I'm sure every healthcare provider has folks of this nature. And soon our southern counties will be facing soaring temperatures and dust storms, sort of the flip side of the winter weather up here at Coconino. Just know that your colleagues in the north are very supportive of your efforts. We are all in this together. So that's the end of my presentation. Thank you, and thank you, Dr. Carroll.
Oh, thanks very much, Mike. I appreciate those comments. Before I ask just for questions from any of our panelists, Mary Jo, Charlton, and others, there was a question that came in. Mike, can you comment on staff? You spoke to it at the end, and trusted partners and colleagues, but how have you worked through challenges of tired, fatigued staff, and even challenges such as overtime or just making things work? Any comments on that?
Sure. So the county was gracious enough to pay overtime for people, and we absolutely we needed that in order to sort of keep them engaged and keep the operation running. We have been fortunate enough to rely on the Arizona National Guard to help with vaccination and also traffic control. We have also been fortunate to have some FEMA vaccinators, and they have been absolutely outstanding. We simply don't have the nursing personnel at our health department to do this single-handedly. So it's been all hands on deck. Department of Health Services has given some of our grant-funded staff permission to be redeployed to this operation, whether it was testing or vaccines. We have to request and they have to approve, but they have consistently supported our efforts. So we feel pretty good about the level of support we've received, whether it's at the county, the state, or the federal level. So
I appreciate that. Charlton, any questions?
Well, I'm going to hold any questions for later, but really great presentation. And also, Michael, there's a great comment about the use of humor and the importance of that in communicating. So there's a lot of good feedback there.
I'll check that out. Thank you.
Yeah, it's nice. It's nice to smile, especially during challenging times when
you have to, right?
Not as many opportunities, right, in the past 12 months. So thank you for that comment.
Thank you again.
Thanks, Mike. We'll now turn to Maricopa County in our journey a little bit down through Arizona in the middle of the state, and ask Dr. Nick Staab, to offer some comments. Dr. Staab is the medical epidemiologist for Maricopa County's Department of Public Health. Before that, many of us had the opportunity to work with Nick when he was with ADHS in the Bureau of Epidemiology and Disease Control. He is also a practicing pediatrician, a pediatric hospitalist at Phoenix Children's, and an Arizona native living in Central Phoenix with his family right now. So Nick, the floor is yours. Thanks for joining.
Yeah, thanks, Mark. I appreciate it. I do have a couple of slides, so I'm going to try to share my screen. Hopefully this works. And I think you will find a lot of similarities to Mike's presentation. It turns out whether you're a large rural county or a large urban county, we do experience a lot of the same, share a lot of the same experiences. I think I've learned a lot of the same lessons. Applied them in different ways, shared what we've learned in ways, that Mike shared that, they've been working with Pima County. So, we have all been in contact throughout this emergency. And I think, that is one of the really great things that has probably come out of this, is just strengthening those partnerships, not only externally, but between health departments across the state. So again, Mike shared what we were asked to discuss. And so I have a couple of pictures to share just as we go through here. This was a picture of our state fairground pod that was opened in phase 1A with Banner Health. And, you know, I think, you know, when I think back to phase 1A, which seems like years ago, and I know it wasn't, but, you know, it really highlights the challenge of coming up with efficient and equitable operations in vaccine delivery. And I think for me, you know, that was trying to develop this way of prioritizing healthcare workers, because we knew that, you know, even though our frontline healthcare workers was a relatively small population relative to all of Maricopa County, it was still a really big population of people, and we weren't going to have vaccine to reach all of them at once. So we went through a very methodical process. We even convened our own mini VAPAC. We called it the Maricopa County VPAC. Got a lot of different members on there to go through a complex ranking system. We developed a screening tool that was released, and, you know, all in this effort to try and get those most at risk in line first for vaccine. And you know, in 24 hours, the tool totally failed, right? You know, there's nothing that will kind of drive kind of an unreasonable demand like a scarce resource. You know, and I thought, you know, we should have learned from toilet paper and Clorox wipes, but we didn't. So, you know, I think, so what we learned there is there has to be this balance between equity and efficiency, and that certainly to some extent in these operations, while we're trying to be equitable and think about those at highest risk being served first, you know, we had to get this resource out into the community. We had to get vaccine into arms. Certainly, the governor's take on that with his executive order was, you know, what you get this week has to be given by the end of the week, and we're going to keep track of that. So, you know, I think in Maricopa County, we really tried to lead with trying to make that balance between equity and efficiency. And so, you know, again, this image of our 1A healthcare worker pods, you know, I think really did a great job ultimately of establishing efficient operations. We were able to take those efficient operations from phase 1A into phase 1B. And some might even argue that, you know, it was the kind of example for the state to take as they turned to their operations in Maricopa County and beyond. So, you know, again, thinking then about these big drive-through pods, right? So once you built them and they kind of started running, like they were just the thing to do. We could efficiently get vaccine out. But as this picture of the State Farm pod shows, you got to have a car to get there. And the access for registration has to be substantial enough that you can get all these people registered. And again, always thinking back to that equity piece, right? So if you don't have a car, if you don't have internet access, if you don't speak the language that the registration system is in, you're going to lack that equity, right? And so, you know, countless hours of pre-planning went into the vaccine management system, the VMS, kind of this online portal for vaccine registration. You know, and again, this is the system that's used by the state at all the state sites, and it was used at a number of our pods. You know, we had partnered with our healthcare groups to run those pods, and so some of them weren't willing to wait for the VMS, which kind of was rolled out at the last minute, and so they used their own vaccine systems, and that, you know, and that is what it was. But I think, you know, ultimately, you know, what we've learned in our experience has been probably just a lot more. If we had more time, that'd be great. But just what we've learned in thinking about equity in these systems, I think is critical. And as I highlight here, the VMS ultimately was released in Spanish, but even talking to our partners now with the Federal Pharmacy Partnership, Walgreens, CVS, other retail pharmacies, they're still working on getting their registration systems available in Spanish. They have a lot of resources for Spanish speakers, but this is just such a huge part of certainly our population in Maricopa County and in terms of access to these resources. So in terms of learning, I will say, one thing we learned, I mentioned prioritization, right? And when we had phase 1A and how to hit that balance between equity and efficiency. And sometimes, you miss a little bit on one in order to have more of the other. And so I think, in Maricopa County, we'd been very thoughtful about how we wanted to go through our phase reopening. It was based on Arizona VAPAC recommendations, but with large state-run sites in our county, there were certainly times when on messaging, we weren't exactly aligned in terms of priority. And so that was very confusing to the public. It was certainly confusing to our call center and those of us who were answering questions for partners, and for all those partners that were assisting us in vaccine operations. What exactly did teachers and childcare workers, who were they? How did you define them? How do you define these other essential workers? How do you define law enforcement? So all of those were areas where we had a little bit of discrepancy between operations at the state and county level. So what we learned from that is, again, for the sake of communications, which Mike touched on, and efficiency, really being aligned in lockstep with the prioritization is important. So, most recently opening up priority to eligible individuals, I will say, age-eligible individuals, all ages, was we followed the state at the same time. And then I think, to highlight in terms of innovations, I think it's one of the most, and Mike mentioned partners, one of the most innovative things has been our ability to bring all the health systems together to both create operations for vaccine, as well as there's a healthcare systems vaccine safety task force that I've been privileged to participate in. And, it's really great to bring all of the resources of these different health systems together to have a unified approach to, how we're going to assess efficacy of these vaccines, safety, how we're going to message it out to our healthcare systems. It's been a really great advantage. And again, it's highlighted on that task force. It was highlighted in the great work that all of these systems did to open pods, learn from each other, and at the end of the day, I think really make stronger operations because everyone came to the table together. I had the benefit of participating in this collaborative approach from my days at ADHS. So it's just really nice hitting the ground running at Maricopa County when we were doing developing vaccine operations to bring all these partners together again. And then the last thing I'll mention just in terms of innovations is related to our school pods. So, looking again at efficiency and equity and wanting to find the quickest way that we could service this population, we went back to the pod model. But at the time, our health systems were unavailable to expand their capacity. We're at a surge of COVID cases. Hospitals were at capacity. The pod operations that they're running were at capacity. And so we needed to partner with somebody else. And so we reached out to retail pharmacies who weren't at the time involved in the federal pharmacy partnership, so weren't planning to start vaccine operations otherwise. And so we ended up working with Fry's, Safeway, and Albertsons to get them vaccine and then set up pods. We'd learned a lot of expertise from managing the healthcare system pods. And then the last thing we needed was a lot of people to help run them. And so, I think we have to recognize the medical volunteers in Maricopa County have been outstanding throughout this operations. It's an impressive, large group of people. But schools are natural organizers. They're community organizers. They already have lots of volunteers within their own systems. And so we're able to bring that technical expertise of the schools together with the technical expertise of the retail pharmacies, and just have had a hugely successful program rolling out vaccination to K-12 staff, including public, private, and charter, and then also childcare providers. So using their ability to communicate within their own communities and reach out to childcare providers and bring them into these pods. So it was really an exciting thing that we saw happen, and we're done with it now. So certainly now that we have more access to vaccine, anyone who is vaccine hesitant to go to these pods initially, there's more opportunities now, but certainly our reaction from the K-12 community in Maricopa County was that this is a really successful operation. And then the other thing I will just say, Mike, I thought when you were talking about the homebound, right? Because now we're just making this transition to kind of hard to reach, whether they're vaccine hesitant or they can't reach the operations that we currently have running. And so what we have done in Maricopa County is, as our long-term care operations are coming to a close, we're taking those teams that have been going out to long-term care facilities and repurposing them for the homebound. And so we just got that started. It's the 30th. We got that started yesterday.
Cool.
So they're going to start. We're going to have between 5 and 12 teams from that long-term care model that will be transitioning to homebound. So
Appreciate that, Nick. Thank you.
yeah.
Nick, thank you. Can you talk just a sec more about the constitution of those teams? How large are those teams that you just were speaking about?
Yeah, so I think as that long-term care project went on, we went from larger facilities to smaller, and so I think the teams scaled as well. I mean, obviously, there's always at a minimum a vaccinator and a county employee who goes and does the registration, and so I think they're a minimum of 2. And then again, since we're doing homebound now, I believe they are just groups of 2.
Well, that's great. Well, I'm sure there are lots of questions that we'd like to follow up with you as well. Maybe what we should do is turn to Terry. Thanks so much for that great overview, Nick. And by the way, shout out to Dr. Sonnenschein for her collaborative spirit and leadership in Maricopa County. Turn now to Pima County and my friend and longtime colleague, Dr. Terry Cullen. Dr. Cullen is the public health director for Pima County, which she joined in 2020. But she has a long career of leadership in a number of organizations at regional and national levels, including the Indian Health Service and the VA, retiring from the U.S. Public Health Service as a Rear Admiral in the year 2012. So Terry, I'm going to turn it over to you for some thoughts and comments, and then we can get into a conversation among all of us here. Thanks for joining.
Good, thanks. I don't have slides. I'm just going to talk a little bit about. I want to preface by what I'm going to say, though. Charlton's on here, and I'm going to call him out here because I actually used a quote he shared with me about 2 months ago when we were trying to figure out what to do with long-term care and Altex, and we were worried about people, all techs would go in, we would arrange for somebody to go in and there'd be non-all techs members that needed to get immunized in a facility. And Charlton's comment was, now is not the time to resolve the health insurance issues of America. And I had that similar comment today where between a county and a state, and sometimes there are issues. And I said, now is not the time to try to resolve everything. We just got to move forward. So I'm going to talk a little bit response to what you did, but I think I want to remind people that if you recall, the initial mantra was shots in arms. And I think from the beginning, we made an error by not nuancing what it meant to have shots in arms if we were really committed to equity. And we're paying that price now as we try to catch up. And I'll share with you what we're doing to catch up, but I'm also going to share with you some disconcerting numbers that should make all of us worry about that. So the first little vignette I want to share, we go live, everything's internet-based. You remember registration. We do very similar to what everybody else did, stand up large pods, different wonderful, wonderful partners from the hospital community. Within 36 hours, 2 different zip codes, same denominator, 75 and over. The one zip code gets 2,425 people registered. The other zip code gets 400. You can probably ascertain which of them had a high social vulnerability index. But that has haunted us and continues to haunt us. And so when we think back about what we've done well, I also think that there are many lessons learned for how we need to, in the future, if we are really saying we're committed to equity. And as somebody from Public Health Service said to me today, equity is not a day-to-day thing. It's how we live our lives and the decisions we make and how it affects it. So I'm going to talk a little bit about priorities, and I want to let people know that in Pima County, the health department, we have stood up an ethics committee, and our administrator always laughs at me and he says, every time you say that, I think of Benedictine monks in their uniform, in their what the garb around it. And actually it's not Benedictine monks. It's a wonderful cross section of the community, but that has really, the concept of using principles to drive decisions is embedded in our ethics committee and was embedded in what we were doing with our response to the pandemic. And so I want to just talk briefly. They're really quick things. They all make sense, right? When you do principles, they're all consistent for most of us: safe, effective vaccine, mitigate spread, equity, community engagement, and data-driven. And so when I'm going to talk really briefly about our lessons learned, do you see those priorities and those principles embedding in it? And we do, I think Nick and Mike are totally right. You know, at the end of the day, there's lots of things, there's core foundational work we have all done that is very similar. In retrospect, I wish the CDC had gotten us a better playbook, so we all didn't need to reinvent the wheel, but we did reinvent. And the beauty of Arizona is there's tons of sharing with the public health officers, and Nick and Mike and everybody, all the public health officers have been more than willing to share best practices, and that's been a really wonderful thing. But engagement of stakeholders, planning and updating. What you guys may be aware is that January 1, we make an audacious goal that we're going to deliver 300,000 vaccines by the end of March. My administrator thought I was crazy. I kind of thought I was a little crazy too, but now we're at 455,000 vaccines. We're not to the end of March, and that doesn't count the U of A pod. So we're probably going to be at 500,000, but having a goal and driving ourselves to meet that goal was a weekly basis. We have a dashboard that we stood up at the county, just like other counties have, but from a vaccine perspective, we really drove, what are we doing to meet that metric? We wrote and published our plans. We made them available to the community. We made the press talk about them. We would talk about what was impeding them versus what were things that were helping us be more successful. We really also made, at the same time, we made an overall commitment and acceleration plan. We did a plan to meet the vulnerable, a plan to meet the homebound, a plan for the rural. So I was a public health service officer, as Mark talked about. So you do a lot of planning, but these were planning documents that then we could implement, but having them enabled us to whiteboard a lot of this work. So for instance, when we look at our homebound, what we realized is we needed 5 different venues to be able to meet the needs of the homebound, because the homebound's not one population, just like the rural community isn't one population. So we would develop those plans, we integrate them and we track them, worked really closely with the two tribes that are here, the Palmatham Nation and Pasquayaki, gave them any kind of help that they needed, but also recognized this kind of reciprocal innovation, reciprocal bi-directional sharing that enabled us to honor all the amazing work the tribe was doing down here. I used to say to people, look, if you want to see how to do this well, go out to the Palmatham Nation or Pasquayaki, because those guys have it. They didn't have the constraints that we had in terms of the extent of not having enough vaccine, but that wasn't why they were successful. They were successful because of the way they approached this from a collaborative, consensus-driven model. In terms of innovations, the other thing that we did was we really relied on our GIS system to give us some social vulnerability, early insight into what our high-risk communities were. We tracked those maps on a weekly basis. We overlay SVI. We looked at, we couldn't get good data on internet. So we did some surrogate markers of what did it mean to have enough internet access into a census tract. And instead of using zip code, we really went to census tract. We can do that in our urban areas. In the rural parts of our county, we still use zip code, but in the urban areas, we rely a lot on census tract data. We did a lot of work with our community health workers. We went door to door in many communities. We did door hangers. I know, Nick, I know you guys did this in Maricopa, and I think it was also done in Coconino. We have set up clinics specifically for some specific communities, those who are deaf and those who are blind. Now, this came because the governor's disability chapter, I don't remember what they're called, but they reached out to us and said, hey, you guys are blowing it. And it was really helpful. And so we actually have had clinics and we plan on having more. We work with international rescue committees. So we have 10 different languages that are spoken in our IRC volunteers. We have church-based pods and that we have happened through community invitations. We actually do a ton of mobile pods. We had 7 this weekend, but we only go in where we are invited. That invitation can be from a school, it can be from a church, it can be from a cultural center, it can be because of a supervisor wants us to go into specific areas. We actually have prioritized based on the SVI because we don't have enough resources to do everywhere right now, but we're seeing those really accelerate. And since we have J&J vaccine, we also have had this great opportunity where we can start with J&J. If we run out, we can flip to Moderna, or we can start with Moderna for second shots. And then if first shot people show up, we can give them J&J. So it's given us more of an ability to not have to turn people away. We also have people I call pharmacy whisperers. We figured out in our volunteers who was like amazing and could get 13 doses or 12 doses, and we made them do videos for us. We're like, you have to do a video. Like, and you ask these people and they look at you and they're like, well, how do you think I know how to do this? I've been doing it 40 years. Like, really, you've been drawing out meds for 40 years. So it's people that know multi-dose vials before there were single dose vials. So we've done lots of cool stuff with that and involved our volunteers a lot, gotten them to come in, do, just 2-minute clips. What's the best practice? And then to get it out there. We've done webinars. We did this wonderful long webinar with our churches, an African-American Black community, which then we've done little vignettes from, but they've been really critical to us getting that, moving that needle. So I just want to talk really briefly about moving the needle, and then I'll be quiet. When you try to move a needle, when you have a denominator 500,000, Nick and Mike know this, you got to do a lot more in a certain group to move a needle. So we've moved our Hispanic from 14%, and I'll just pick on that one, to 16.3. It means on average, we have to now immunize 25 to 30% of people who are Hispanic if we immunize 100 people. That's the only way we can move that needle. We have to move that needle. That is a dismal percentage, even though we're the second best county in the U.S., in Arizona. It's a dismal percentage. And so we drive ourselves every day. We're happiest when 90% of people at a pod are monolingual Spanish, because we know we're getting there. And as an aside too, because of our undocumented concerns, we do pods at the consulate, because people are really trusting at the consulate, or at, interestingly enough, the Hispanic Catholic churches. They seem to be the two places where we don't worry about that. And so I'll just wrap it up by saying shots in arms is not all that matters. If at the end of this, we still have the inequity we started with, we've saved lives. It's really important, but it's not enough. Thanks.
Well, thanks. Thank you, Terry. Boy, what a breadth of work is going on in Pima, and I appreciate you sharing some of that perspective. It makes me wonder how we can continue to capture both lessons learned, not as a historical exercise, but as an active now moving forward activity. I think that's what part of today is intended to do. Dr. Wilson, Charlton, I'm going to turn it to you for thoughts, comments, and questions, if I may. Thank you.
Well, thank you, Mark. 3 fantastic presentations, great work, and representative of things happening across the state. Each one of you talk about the importance of these partnerships. And so in a classic kind of facilitator thing, I have 2 questions for you. Name some things that really made these partnerships so active these times. It seems like they're more active than they were usual. And then next, what's it going to take to continue these partnerships? And Mike, if you're ready, we'll keep the order going there.
So Charlton, the first question was why?
You seem like you've everybody described some new partnerships and a willingness for partnership. Was it what helped create these new partnerships?
Well, I think a large part of it was our outreach efforts. And I'm really was delighted to hear Terry and Nick speak, because they gave me ideas about, oh, we should consider that as well. And so I will be in contact with each of you after this. So I think it was the outreach efforts. I think, for many of our partners, this was the first time they ever came across public health. So we worked with Forest Service people and wildland firefighters. They have generally no contact with public health up until this point. And so it really was our opportunity to say, this is what we do. This is how we promote community health. So I was really intrigued by that there were people that were in the shadows of public health, and now they're singing our praises, and they're singing praises of public health across the state as best as they can. So, and then your question is how to continue it?
Yes.
Boy, hopefully some of these grant opportunities we have to continue our COVID work, we can build in strategies to keep the connections going. It would be unfortunate if they just sort of withered by the wayside when somebody declared, "Up, the pandemic's over, let's all go home." I hope that doesn't happen.
I agree. Nick, how about you? What any thoughts?
Yeah, I think a lot of our partners, we all know in public health that we have a lot to offer, but a lot of our partners, as Mike said, didn't know us or didn't know what we had to offer. Finally, we had something that they all wanted, and they wanted it desperately. So we had their attention. And I think, to Terry's points, we've certainly done some things right, some things wrong, but we've been able to get vaccine out, which for a lot of these partners, I think has really meant something. So I think, moving forward, we need to take these partners and convince them that we have ongoing things to offer. It doesn't just stop when vaccine stops and the pandemic's over. And one thing is, we've developed relationships with our schools that we never had in public health. Again, finally, we had something to offer, not only vaccine for educators, but all of the infection control that goes along and contact tracing and all that. So I think there's an opportunity in the example of schools to take those partnerships and say, we can take everything that we provided for COVID and we can do it for other diseases. This doesn't apply just for COVID. I've watched our numbers at PCH plummet this winter because we don't have RSV and flu. And that's because what we did for COVID works for those diseases too. And I don't want everyone to be masked and socially distant in kindergarten for the rest of their lives. But there's certainly things that we can take back. And I think that's where, whether it's schools or businesses, these relationships that we're creating in these communities. We have a refugee outreach unit that started as contact investigation and tracing. And now it's turning into, using those same partners to develop vaccine programming. And then we just continue to move the needle and say, there's a lot more that public health can provide. And now that we're going to have a lot more money, I think we can really think about how to do that.
Okay, great. And Terry?
Yeah, I would echo what's been said. I think the other thing that is really important to note is that we have, our county has, I'm lucky, I live in Pima County. Not that you guys aren't lucky, and I missed that snow in Flagstaff. I couldn't imagine running a clinic in the snow. You have my praise. But we declared racism as a public health emergency in the fall. We have a board that has basically said public health matters. We're embracing, just for all of Public Health Week National Public Health Week is April 5th. And there's this opportunity to do all this stuff with your community about why public health matters. Public health has been an afterthought. I tell our board that the funding we have is a rounding error, and they should be ashamed. Now, I don't really say that to the board, but I say that to some people. And if you want public health to exist, and I think Nick and Mike just said this, there has to be ongoing funding. So it's one thing to get people to commit in theory, public health matters. But if public health continues to be a rounding error in terms of budget and finance, we will be in this same situation. And I think it's just important for people to recognize that we have foundational infrastructural enhancements that have been developed that need to continue, and that requires human and fiscal resources.
Yeah, great. Well, fantastic. And I'm going to paraphrase some comments that are on the chat room there and sort of go to the things that you've pointed out there. You're visible, you're communicating, people see the value in what you're doing. And then also people are actually seeing it turn out in results, right? As opposed to some maybe vague thing about what is public health. People say, hey, I receive vaccination, or I recognize my community is healthier. I've been able to get something. So what a great time for public health. And I agree, something that we ought to all continue to work on. I know we're getting toward the end of time here. I do have one other question that I would love to get out, and maybe a quick one, and then obviously Mary Jo may have some comments as well. But is there something in our data or data infrastructure that we need to do that's a learning from this pandemic? And I'm going to start south and go north this time. Terry.
Well, I've spent the last 25 years working on data. I think there's lots of things, but the one thing I am humbly reminded of is that the digital divide is real. And we need to really look at what it means to have data literacy and what tools we give to people that are struggling with access.
Great. Nick.
I was going to say, see, I'm so naive. I was going to say the data's perfect. There's nothing wrong with the data. No, I think, and the divide is not just in the public, but it's in public health, right? So, I mean, as information systems have, developed at warp speed, our systems in Arizona public health have not, in terms of collecting data. Sure, we have labs reporting into MedSys, and there's certain things that have developed, but again, no provider or county is going to tell you that ACES is working very well as a vaccine information system. And here we are in this critical time in these critical operations, and we don't have good data to help support the decisions we're making. So I'll probably get in trouble for saying that, but I think we just need to keep our eyes on that. We can't be working with systems that are 10 years old in an age when these systems get better every month.
Excellent.
Yeah, I would just add that the specialized funding we're receiving, it's great for COVID, but that doesn't help us long term. So Nick is spot on about the aged equipment that we're using and the technology we're using. We need something that can keep pace with the changes, and it can't be designated funding just for disease specific.
Well, what's really cool from all of your comments there, it's not only the human relationships and these partnerships and all that kind of stuff, it's also the technical infrastructure of data and data systems. And all of that's going to require some investment of both time and treasure for us to do. So, but great opportunities, and boy, the timing seems right. Mary Jo, I don't know if you have any comments. I'll scan the chat room, and I'll encourage anybody who has a last minute question that they want to get in there, get it, and I'll make sure we ask.
Just two comments. Thank you, Charlton. One is this has just been an amazing overview, and thank you all very much. I think we witnessed a scientific revolution right between our eyes and in front of our eyes as we all tried to fix the plane while we were flying it, and it's an amazing accomplishment. I think there is a curation opportunity here to all of your points on being able to collate and protect and share all of the great lessons that were learned throughout all of this. And so maybe that's something, Mark, you and I can talk about, some curation opportunity. The one question that I did have is, as this proceeds, where do you see the opportunity for the kids? We talked a little bit about schools, but are you seeing a true possibility of summer or fall vaccination for 12 and above? Or do you think that is really still science fiction for a while?
So I will
Nick,
defer to Nick and
okay,
Terry.
Mike, yeah.
No, go
Okay.
ahead, Mike.
No, please. You guys are the physicians. I am not.
Well, I mean, I don't think any of us have that answer, right? So, I mean, we continue to be surprised by what happens. I think it'll be fascinating in the next week or two to see what happens with AstraZeneca. Beyond that, they were probably the closest to pediatric data because they had used their platform previously and had some data on peds, but I'm sorry, as has Johnson & Johnson. So I don't know. I think it's hopeful that by the fall that we have something. But again, our schools, what we've learned is that the mitigation is so powerful in schools, and that schools can operate safely even if those kids are not vaccinated. We know how to do that. We have better guidance for them now. It's not a make or break it for schools.
Yeah, I would agree, and I would defer to Nick.
Well,
Great.
Thank
Well,
you.
thank you.
yeah, in the interest of time, Charlton, thanks so much for facilitating that great
thank you.
conversation. And Mary Jo, thanks for helping us frame how we might together contribute, support your efforts in all the county's efforts in public health moving forward. Learn from this, but learn in actionable ways that we can bring improvements today, tomorrow, and moving forward, acknowledging, of course, that this all happens in the context of historical and structural and systematic challenges such as structural racism and inequity that have existed for a long time, and that these things are not addressed in isolation. But that concludes today's session for Arizona Community Grand Rounds. We look forward to the next rounds on April the 15th, when Dr. Dennis Cortez from ASU will speak on the civilian medical emergency medical system. Is it time? Again, we welcome everyone's ideas and suggestions about rounds moving forward. A big note of thanks to all of you, our presenters today, Dr. Wilson, Mary Jo, Jen Pierce from Health Choice. Thanks for supporting us and making sure these sessions come off technically flawless. So I appreciate that. And a real note of thanks to everyone in the state, all counties, all collaborators, and everyone who continues day to day to take through the lens of equity and the framework of important public health principles, as Terry noted, advances the opportunities for everyone, including our most, and especially our most vulnerable and highest priority folks, to be able to access vaccine through the innovations in our work, our relationships, and our efforts. So we'll close and continue to please spread kindness whenever you can. Thank you all.
Thank
Thank
you.
you.